As we do pre-wedding shoots, there should be some kind of pre-wedding counselings, pre-wedding sexual counselings, and we should spread this kind of awareness in the normal population. जनता को बताना है कि आपके बच्चे की शादी होने वाली है, एक तो उसका काउंसलिंग बनता है उसकी डॉक्टर के साथ. Thank you, sir. Thanks for giving me this opportunity once again, because the earlier attempt was failed. So the failed attempt was there. So I'm trying again. So please support me. And this is the post-lunch session, you know. And the topic is vaginismus, a sad story. But yet I will try to do some justice with my subject. So the topic allotted to me is Vaginismus Management with Dialator versus Botulinum Toxin. But I'll take a bit of vaginismus as such also, because this is a subject, this is a topic which should be talked upon. Many times in our OPD we get many patients, and there is a debate, there has always been a debate to the fact that this is a psychological disease or this is actually purely a sexual disease, something related to gynecological problem. So, a big hello, namaste, adab from Lucknow. I'm Dr.Poonam Mishra from Lucknow. So, here I am, and extending my gratitude to Dr. Ajayan, he is not here, for giving me the opportunity to speak upon this subject. This is very close to my heart, because in my practice, I get these kind of patients, and now my friends are referring such patients to me. They know that I'm very much interested in this subject, and I'm trying to make out like where we are lacking, why such patients are not getting proper treatment. So maybe I would come with some paper or some publication after some time. So we all are friends here, and we are, like जैसे कहते हैं ना, sexually linked disease, we are sexually linked friends, you know. Sexual health यहाँ पे हम लोग discuss कर रहे हैं. So vaginismus is a sad story. This actually finishes the family. And vaginismus, मैं बहुत ज़्यादा impressed थी, और बहुत ज़्यादा like Dr. Brahma Bhatt sir की कहानी के हमारा राजा रूठ गया है, मुन्ना बात नहीं कर रहा है types, he gave the presentation that time, and I thought that yes, we never talk about Rani or Munni sort of things, because many times the OPD में जब भी ऐसा कोई couple आता है तो वो क्या बोलेगा और कैसे बताएगा, because this is a female story and females never speak up, they never open up. But actually vaginismus एक रूठी हुई रानी की कहानी है जो शादी के बाद पता चलती है. And the sad thing is that I encountered a patient, a couple, who were dating since last 5 years. They were in love. Our cultural, like our society is not permitting that kind of like sexual exposures, premarital sexual exposures. That is why they couldn't understand. But after marriage, they got to know that the lady was not permitting for any kind of relationship, for any sort of conjugal relationships. So what was that? और आज सुबह से मैं सीख रही हूँ, हर लेक्चर में मैं सीख रही हूँ सर, एवरी टाइम, लाइक इन योर लेक्चर, आपके में जो क्लाइटोरल आपने जो बात करी, मे बी आफ्टर सम टाइम जब हमारी सोसाइटी थोड़ी सी इम्प्रूव कर जाएगी, बिकॉज वी टॉक अबाउट मैरिजेस, वी नो अबाउट, वी टॉक अबाउट जोक्स, यू नो, नेम मिस्टर महेंद्र, एज 26, कास्ट हिंदू, सेक्स बार बार. सो इस काइंड के हम जोक्स सुनते हैं, बट कोई कभी भी इस बारे में बात नहीं करता. हम बात करते हैं मैरिजेस की, वी टॉक अबाउट मैरिजेस, वी गिव लाइक एडवर्टीजमेंट्स, एंड देयर व्हाट हैपेंस, एवरीथिंग, एवरी सॉर्ट ऑफ सीक्रेट्स ओपन अप आफ्टर मैरिज ओनली. The female is not compatible, female is suffering from vaginismus, female is having a short vagina, some sort of congenital anomaly, the male is having erectile dysfunction, some premature ejaculation or like that. What kind of things are these? Actually, we live in a society everywhere. पूरी दुनिया में इस बारे में कभी बात नहीं होती, तो शायद जो आपका डिवाइस है, maybe some sort of scaling would be there, और फिर ads आएंगे कि this female is this and her scale is very high, her scale is medium, her scale is low, और maybe कि males की ओर से आएगा कि he is very compatible for that high scale female, he can go up to that, he is very patient, he will wait for that kind of. What happens? See, in those relations, they never actually, the male partner is in a hurry, and female, you told that if she is not having any sort of orgasm, then it is some problem is there with the partner. Partner is not doing well with her. Maybe her threshold is very high, but you should know. So there should be in marriage advertisements that yes, the female is of very high scale. You know, she needs a patient partner who has got a very patient mind. He will help her in having, like in her married life, they will have some sort of relationship where orgasm is there for female also. This is her right, and why she should not get that kind of pleasure in her life, in her marital life. And this is the crux, this is the story everywhere, nobody talks about that. In my OPD, I have encountered another patient where 14 years of marriage. At the age of 41, the female was coming, non-consummation of marriage, and they were there for just baby. कि एक IVF कर दीजिए या IUI कर दीजिए, whatsoever, but हमारा काम चल जाता है. And that kind of, that clitoral orgasm, or some sort of, you know, cuddling, fingering, and other things which give some sort of satisfaction to the female, that, in my opinion, is actually forbidding or doing some sort of, creating some sort of problem for their penetrative sex. They are satisfied with their life and they don't go to the doctor, and they think that yes, sometime, maybe after some time, and see, 14 years have gone. So the definition, I will not go more. Marion Sim gave this definition, and causes are emotional and physical both. Most of the times there are emotional conditions where past traumas like sexual abuse and other things, or talking to the friends, or some kind of that there is tearing pain, there is something, some havoc will happen, very like severe kind of pain is there. Patients tell. These all things are told by the patients only in my OPD that, ma'am, I just lock myself. I know that I am wrong, but this is एक थोड़ा सा obsession हो गया है. एक OCD है कि this I cannot permit. And prevalence is very high. Half of the world's female population suffers from some kind of sexual dysfunction, though it has been quoted that it is only 7%, but the incidence and prevalence is very high. Differential diagnosis can be vaginal muscle spasm, superficial dyspareunia, or whatsoever. Patient comes to you, you have to just decide, and there we come to know that yes, the patient is having some kind of mental problem, because you are examining her, you are doing bimanual examination, per vaginal examination, and she is permitting. But when husband attempts, she is not permitting. That means there is some kind of mental block, thought block. But if the patient is ready, the patient is trying to be conjugal, she is doing everything, and yet she is not able to get conjugal. You are examining and she is just jumping, she is just not letting you examine her. There you get to know that this is a real case of vaginismus. Vaginismus is actually the spasticity of perivaginal muscles. 1/3 of vagina, the superficial muscles, and sometimes deep muscles also, they actually become spastic, and they are very painful once they are touched even. And I've seen such patients. And the cycle of pain is there. There is anxiety, there is anticipation that yes, something will happen, and when the relationship is tried, she again goes into some more tension, some more anxiety, and more spasm occurs. types could be the primary one where never ever she has a, and one thing more is there, some psychological things are there. My anesthetist was telling that in his family there was a couple and they were not conjugal, they were not, non-consummation was there, the patient was having vaginismus, and somehow, most of the cases of vaginismus I have seen and I have heard that the husband goes into erectile dysfunction after some time. This happens, every time this happens. And the same happened over there also. Now the thing was that the husband is not able to perform and female is not allowing him. And after some time, there was the divorce. They both got married again, separately, different partners, and they were happy. So something is there, some evaluation is needed. What is there, what is the cause, root cause, this has to be actually taken out in such cases. So this could be secondary. In some cases, everything was normal initially, but later some pain or something happened. That could be global. Anyhow, any sort of stimulation is not going to cause any kind of stimulation to her, or situational. Sometimes she is aroused and sometimes she is not permitting. That could be spasmodic and non-spasmodic types. So different types are there. Different causes are there. So in the diagnosis, we have been hearing since morning, history plays a very important role, because once you take a detailed history and there only you come to know that she is now, you have screened the patient now, what kind of treatment she needs. You have to refer her to your psychiatry friend, some psychiatrist or some psychologist, or you have to treat her because she is having some kind of gynecological problem. So genital examination you have to do to exclude organic pathology, and several consultations may be needed before the woman is ready to be examined. Many times she is not even ready for the examination. And classification, a very smart classification has been given by Lamont and Pasek. And there, grade 1, grade 2, grade 3, grade 4, and last one is the grade 5. And I've seen patients in whom I was trying to give that botulinum toxin injection, and she was under GA, short GA. And there also she was lifting her buttocks. So there we decided that, there we came to know what kind of relationship she was having with her husband and how she is going to permit him. Because she is under sedation, she is under some kind of a little anesthesia, and even then she is worried. She is locking and she is dragging herself back. So treatment, the aim is to break the vicious cycle, replacing pain by pleasure, spasm by relaxation. This is the need. Once we achieve this, everything is going to be solved. Maybe it would take some time. Requirements are warm, sympathetic attitude and great patience also. Treatment. In my OPD, even I just got her lie down and I was asking her, do you masturbate? Yes, I do. Do you get orgasms? Yes, I get clitoral orgasms, but I have never allowed him to penetrate. I don't know about the vaginal orgasms or any sort of penetration. This kind of things are there, and those are the patients who are willing to get treated. And those are the patients in whom our role comes. The gynecologist has to do, or the sexual health expert as well as a gynecologist has to do something. So lines of treatment, exploration of phobia, history, false beliefs, like in the social, the culture of the family, the cultural situations and other things. The sex education, which is still, there has always been debates whether it should be there or not. Sexuality education, the newer term. It is still not there everywhere. Anatomy, physiology, and control of muscles like adductors. Their relaxation exercises are to be told to the patient, and pubococcygeus muscles are to be trained, the Kegels exercises. As the question was there in the morning, like if you are stimulating the clitoris, you were asking, and the muscles will get much more spastic in case of vaginismus. So the aim is here, the aim is to tone those muscles, to get the control over those muscles. So these Kegel exercises are not going to give more spasticity or more contractility to those already contracted muscles. Actually, they are giving the control over those muscles. Here, the role of Kegel's exercises are different. So in last year, I was in Bucharest, and there they just gave some kind of device which was giving some sort of vibrations inside the vagina. They were quoting that if you put it inside the vagina, it will vibrate and it will actually give some sort of exercises to the deep pelvic muscles. And from that, the vaginismus and other conditions where the ligaments get थोड़ा सा time लगेगा. The ligaments get relaxed, and different problems are there, some sort of prolapse and other things. So I just took few of them and I just gave to my patients, and they were very happy because they were getting orgasm with that device. So they were happy. So that is also the need. Why? The patient is not worried about the weakness of the pelvic muscles. The patient actually needs pleasure, which she is not getting in her regular marital life. So let me come to the next part of the treatment is systematic vaginal desensitization, which we get with the help of dilators and botulinum toxin and other modalities. So the topic is dilators versus botulinum toxin, but in my opinion, they both are actually have got synergistic effect. The dilators as well as botulinum toxins, they both give very good results. So the Kegel's exercises, benefits, I'm just skipping. So we are coming to vaginal trainers. These are for systematic desensitizations. And Botox injections in vagina for vaginismus treatment. Now we are coming to that. Since vaginismus is a muscular problem, we come to know with examination that perivaginal muscles, the ischiocavernosus, the bulbospongiosus, and the deeper ones, the levator ani, the fibers of that, they also get contracted and they are very painful, even on touch. So they actually need some kind of treatment which actually completely relaxes those muscles. And we need such patients where the patient herself comes to the doctor and tries to ask for the treatment. That yes, I have been struggling with opening up lately. So there is the problem with opening up. So how Botox helped her to have pain-free sex. Systematic desensitization with the treatment of dilators, we have been doing since very long. I was in my graduation there also they were telling. But botulinum toxin, what does it do? It actually, at once it gives quick relief. So it expedites the treatment. The whole time taken, like years and years are wasted with all those exercises and in the hope that this desensitization is going to help in her after some time. That all time is saved with the help of botulinum toxin. All those muscles are relaxed. We just send the patient back with a dilator inside from the OT. That gives her a kind of relief that yes, she is having something inside the vagina and yet she is not having any sort of pain. So treatment with botulinum toxin, at the same time desensitization with dilators, that gives synergistic effect. So what we do this botulinum toxin treatment, which is obtained by Clostridium botulinum, and the onset is 3 to 7 days after injection. Duration is 3 to 4 months. Every time I have been asked that whether the top-up is needed, no, not at all. None of my patient has come back because once the penetration is there, once the pleasure is there, everything is okay. Now she knows that yes, the problem is solved, and in 3-4 months, she's used to that penetration and that conjugation. So how we prepare, we just get 100 units vial and 50 units botulinum toxin vials in the market, and we prepare the 100 units because in vaginal, perivaginal muscles, we divide this 100 units into 50 units right side, 50 units left side, and these 50 units are divided as per the need. There is nothing like, yes, I'm going to tell that 20, 20, 10, 20, 20, 10, both sides, but it is up to you. You should examine your patients because in my practice in last 2-3 years, I have come to know that many patients are not having any kind of spasticity in the superficial perivaginal muscles. But when I went inside, the levator and that also in one case on unilateral, the single side, on one side only, that was a spastic. And I gave a bit of botulinum toxin into that deep fiber, just a single shot, and everything was okay. Patient was very happy. So 100 units are prepared with 2.5 ml of normal saline. So 2.5 ml, if it is taken into insulin syringes, then 1 ml, that is 40 units in one syringe, 40 units in the other syringe, and 20 units, that is 0.5 ml in the third syringe. So we divide in that way. We load these injections in this way, and this we can just keep it, prepare it at the time of injection only, don't keep it, but if needed can be refrigerated. And then because time is come, so reconstitution and handling is botulinum. Those who are practicing aesthetic medicine, they know how to prepare that botulinum toxin injection. Botulinum toxin powder is there in the vial, and you have to go from the lateral wall very slowly, very gently. You don't have to create bubbles. You don't have to give some shaking action to that. Very slowly, like we prepare DIMPA injections in our OPD. We prepare very slowly, and the solution is prepared because the potency is lost once it is shaken heavily. And then, as I told, in 3 insulin syringes, 40 units, 40 units, and 20 units, you can divide into 3 insulin, 2.5 syringes, you can say. And this way, we just, this is the technique. I am giving the technique for 100 units. Practical is 100 units divided into 20, 20, 10 on each sides of superficial muscles if you are going from the outside, or if you have mapped out all the muscles inside the vagina, which one is a spastic, you can go inside also. Put some speculum inside, Cusco's speculum, and just rotate it and go in whatever fiber you have to go and inject this botulinum toxin inside. You have to just avoid the 6 o'clock position because there the puborectalis muscle is there, and if that gets injected with botulinum toxin, the permanent 3 months fecal incontinence is going to happen. So some skill is needed. So get trained by some cosmetic gynecologist and then start doing this, because this is going to help. I have been doing this and many patients of mine are relieved. They are very happy. They have given the testimonials and few have got pregnant also. One couple was there, after 7 years they got that consummation, and then she came with the pregnancy. So that is so rewarding in your practice if you get that sort of relief. These are the muscles. This is the division, the hymen, and once you go inside, the bulbospongiosis, which is covering the bulb of clitoris, and crura of clitoris is being covered by ischiocavernosus. Deep inside is levator ani. The puborectalis is to be avoided, as I told. So how often is botulinum toxin used to treat vaginismus? As we discussed, in most cases, a single treatment is sufficient. And indications, contraindications are much more important. Indications we have discussed. Hypersensitivity to albumin, botulinum toxin, or any component of the formulation, because these days many females go for, or males also go for those removal of temporary lines on face. So botulinum toxin has been injected, if has been injected into the muscles, the facial muscles, and if there has been some history of hypersensitivity, then we have to avoid. But there has never been any report about that hypersensitivity. So diseases of neuromuscular transmission, coagulopathy or therapeutic anticoagulation. If some blood thinner is there, so we have to avoid. Otherwise, there has been no side effect or no contraindications. Side effects are no major, fecal and urinary incontinence lasting 3 to 4 months if it has been injected. It is very, very like unusual if you are going into 6 o'clock or 12 o'clock position. Otherwise, nothing is going to happen, because once you inject at a point that botulinum toxin, that spreads 1 centimeter peripherally. So you know that you are injecting at some point and you have to be away from the anal pore or the urethra. So 1 centimeter, if you are avoiding just 1 centimeter, you are not going to have any sort of side effect in your practice. Results are very rapid, most of the success after first treatment, but occasionally repeat treatments were required. But in my case, I have never got my patient coming back for the top-up. And yes, we are just skipping other modalities. We don't have to talk because the topic has been the dilators and the, I should skip, I think. What can be done to prevent vaginismus? Sexual education, premarital sexual counseling and guidance. I have given some reels also. As we do pre-wedding shoots, there should be some kind of pre-wedding counselings, pre-wedding sexual counselings, and we should spread this kind of awareness in the normal population. जनता को बताना है कि आपके बच्चे की शादी होने वाली है, एक तो उसका counseling बनता है उसकी डॉक्टर के साथ. So we have to get that done. And conclusion is vaginismus muscle spasm is not a valid or reliable diagnostic criteria for vaginismus. Clinical syndrome that consists of overlapping element. There could be some other kind of pain problems, anxiety, difficulty in penetration because of some other reasons also. So we have to rule out that. And lines of treatment are exploration of phobia, sex education, control of the muscles, systematic vaginal desensitization, injection of botulinum toxin. So we need our patients, which has come in our OPD, that yes, I'm not allowing. And now after the treatment, she is saying, don't stop, don't stop, don't stop. She needs that kind of pleasure in her practice. So thank you. The sad story has got the happy ending. You know, here it is. And this is a small, sir, announcement, because we are doing, ours is Indian School of Aesthetic Gynecology, and there we are giving hands-on training and trainings also in some kind of small courses, small modules are there. So 24th and 25th June, we are going to organize basics of cosmetic gynecology and injector course also. The second day is injectors, this botulinum toxin, fillers, hyaluronic acid fillers, and PRP injections for sexual enhancement in females. The second day would be for that. So we are going to organize. Thank you very much.
Excellent presentation, ma'am. I have one query and one experience also. If botulinum toxin is not approved, so if there is any complication, is there any legal liabilities?
What kind of
As you told me, any kind of complication like fecal or urinary incontinence or any kind of allergic or anything.
So one should learn first. One has to avoid only the 6 o'clock, the anal pore. This is 1 centimeter around the anal area. You don't have to go into that. Otherwise, do whatever you want to do. On face, if you are doing something on face, there could be asymmetry.
If it is open in the market, so is it legal? Means we can do in routine OPD procedure or is OT procedure?
Of course, it has not been, FDA approval nahi hai for botulinum toxin in gynecology. कुछ ही है, मैंने वो slide miss कर दी. FDA approval for botulinum toxin in medical sciences, 12 उनके वो बने हुए हैं, list is there. But
if we do in routine OPD, then is there any legal complication? Means anyone can suit us for the use of botulinum in vagina?
Of course. If you are going to create some sort of havoc,
yes,
then only you can get that. If you are injecting something, कोई भी abscess बन गया, whatsoever happens, you are going to be like responsible for that. That kind of.
One of my experiences actually, as a psychiatrist, I am dealing with vaginismus. Till date, I have around 12 patients. We are doing relaxation, systematic relaxation, and self-stimulation. And touch wood, we are getting 11 patient out of 12 is successful and they get pregnancy. So what
But
I feel,
I totally agree. I just
Thank you,
demarcated,
sir.
2 lines were there.
We are running out of time. Can we discuss in...
I just wanted to convey that yes, you have to decide that this patient needs psychological treatment, and this is the real vaginismus case. This is a case where muscular spasticity is there. Their systematic desensitization is going to take a long time, maybe years. And even then after years, that is not going to, a person is not going to succeed in that treatment. There only the botulinum toxin is going to
My
be
one
successful.
question to Dr. Poonam,
Yeah.
is there any antidote available? Suppose if we miss...
The antidote is not needed for botulinum.
Suppose if we
No,
miss.
no, no, nothing like that. Nothing.
Okay.
So, see, I was telling that on face there is asymmetry kind of things. If you are putting somewhere, one eyebrow is lifted, one eyebrow is drooped, that could be, the patient can sue. But in vaginal area, nothing is going to
Question
happen.
of suing, it is just because if at all we miss, then there should be some correction. That is what I was talking about.
But it is not needed at all, nothing. And if something happens, it is going to last for 3 to 4 months. Be prepared for that. Yes. Yeah, sir. Exactly. Yeah, because the patient is not going to come for that. But yes, this is the era of
In case.
IVF and assisted reproductive techniques. Yeah.
Thank you, ma'am. No, ma'am. Thank you, ma'am, for a wonderful session. I invite Dr. Radhakrishnan sir to felicitate, ma'am.
Thank you.